Welcome back. We're going to move into the public comment period. We don't currently have anyone signed up to give a public comment. However, I'm going to pause, check with the host before we move on. Are there any folks who want to contribute? Okay, great. So hearing no public commenters, that will be the end of the public comments, and we'll move right into committee discussion. So the committee members and I are going to discuss what we've learned yesterday and today from our guest presenters, the roundtable discussion, the background materials. As you know, this two-day meeting is part 2 in our 3-meeting series on population-based total cost of care models. After all 3 meetings in the series are complete, we will submit a report to the Secretary of HHS. So the report will include our findings from the March, June, and September theme-based discussions. But while it's fresh in our mind, we want to discuss what we learned yesterday and today. Lots of information to sift through. So committee members, please check the pocket of your meeting binder for a document of potential topics for our deliberation. Our goal is to begin developing comments and recommendations that will inform the portion of our report to the Secretary on care delivery best practices and innovations, and to pave the way for our September discussion of payment methodologies to encourage what we've identified at this public meeting. As you make comments or ask questions, please remember to flip your name placard up. So I'm going to open it up now to the committee members, and we'll get started. So, Jay?
Thanks, Paul. One of the things that stood out through every session and it generated a lot of questions by the committee is, how do we integrate specialty care and specialty cost into a total cost of care model? And when I struggled with this back in my insurance days, and I think we all struggle with it today, and that is, if you believe that who's ever responsible for the care is responsible for the cost, then that should be the accountable party. And in many circumstances, for many conditions, the specialist is the best person suited to get the best patient outcome. So somehow, we've got to figure it out. We can't just say, we keep putting it in the parking lot because it's so difficult to deal with, but we really do need to figure it out if these plans and models are going to be successful.
Yeah, I appreciate that comment. Others' thoughts, particularly on that topic? And I know we've asked several of the panelists around this, how to either incentivize specialists, engage specialists, and to your point, Jay, there are certainly, thinking about best outcomes and how specialists can engage in the cost of care model. So, Larry, I'll start with you.
Well, the term that you used early in the meeting on yesterday, cascading accountability. Forget primary care, specialty care. We've designated those definitions, but they're fluid in many respects because a specialist following someone with a serious chronic disease has to be providing primary care for that illness to that patient. And likewise, the internist who's managing multiple complex conditions who may be experienced is delving into the specialty world in multiple specialties at the same time. So I push back on this definition of primary and specialty care, and I keep coming back to what is total care for the patient depending on what the illness is. And we know from what we've heard over the last couple of days that the frontline work has to be proactive. And it has to have whatever touches are necessary for that person's illness, that person's SDOH status, whatever number of touches are necessary, those touches have to be made. And whether they're made by a primary care doctor or a specialty physician, or a nurse practitioner or a PA, whoever's performing this, or even an unlicensed person, we have to define the touches to the patient. And then if we want to be able to pass responsibility for cost onto a population-based total cost of care model, we have to be able to envision the layers of accountability that have to be created there. So I heard a lot over the last 2 days about frontline work. I'm starting to get comfortable on what that frontline proactive primary care work should be. I didn't hear enough on the specialty side, but what I think I gathered out is we either need to use tighter networks so that the number of patients a specific specialty group is seeing has enough critical mass for them to change their practices. And either it's the number of patients they're seeing or it's a financial driver. But in order to get into that specialty space, we're going to have to look very distinctly at what type of services they provide are bundled, because they're low variability, they're high volume, they get bundled, but that gets nested inside this total cost of care. And then what conditions they're managing, and how do we provide the care management support there. It's obviously very complicated, but those are my takeaways from the 2 days.
Yeah, that's great. Very helpful. Yeah, and as I think about cascading accountability in the comments you made, I think it also requires sort of a culture change even amongst the specialists. And again, speaking as a specialist, where even on the quality side, so depression screening, I hear endlessly specialists saying, well, I'm not accountable. I don't do that. But really, it's the collective accountability, and you're sort of within that cascade of accountability. It's for us to move all of this forward. You can't be the bucket of this is primary care, this is specialty care. It needs to be think how we can do this sort of more collectively. Josh?
Yeah, I agree with those comments. And I was just going to say, to me, lots of good things to noodle on for me over the last few days. I think I returned to a few things with regards to engaging specialists. One is, do we think populations, their care is just ongoing in a kind of monotonic, ongoing way, or are there kind of curves to other episodes that come up and down? That's one. The second is, in some of those episodes or the kind of patterns of care, do we think specialists play a key role in that? And then the third is, do we want to go by who's touching versus that's the phase of care where more people are needed? I tend to favor the latter. And the reason is, even in the primary care setting, we were hearing even some of that outreach is not traditionally the primary care physician anymore, right? It's other team members, some are licensed, some are not. So I think the who's touching is not as important. Thinking back to the idea of centering on patients, it's when that patient needs something to be able to define that moment and then ask the question, is a subspecialist a key player in that? And so, listen, lots of, I think, technical work needs to go into it, but, I do think about this idea of nesting, and I think about nesting in that way. And personally, I think, we want to be careful of avoiding kind of the tail wagging the proverbial dog a little bit, because, some of the comments about, well, it takes the incentive away, the margins are small, 18 months is retrospective. That's true. I just want to call out that in total cost of care models that engage primary care docs, that's what they're dealing with already. We've been dealing with that for a long time. And so those are issues to address. But the main issue is, should we find a way to bring primary and subspecialty care together for those parts of the care that need both? And personally, I think the answer is yes. And I think those technical things can be worked through and need to be worked through. Things like cost accounting and who gets assigned what costs, we need to work through that. But I take the optimistic view that we should do it. And until we do that, I think things like nesting or other ways of doing it that acknowledge that those parts of the care that need those team members, not who touched them last, is important to me.
Yeah, that's great. Lee?
I think something that I heard throughout multiple talks, and I think many of the members around the table have commented on, we've good, robust discussion on, is just about the centrality of the data that's required to impact access, affordability, and fragmentation. And having a essentially all source, normalized, timely, updated, no one EMRs is good enough, no one or even three payers is good enough. It's got to be all sources all the time, which can only be done on big standardized national framework, which is already coming together. So I think this is a huge leadership opportunity for CMI in three different parts. One would be to, proceed with bold policy making and set the standards for how that all source data should be, what the nomenclature is, how it should be standardized, normalized, and set some bounds to that. The other would be to essentially change CMMI's actual paradigm around data, that data is a siloed treasured resource to be protected and closeted, to it's a health data utility that must be ever present and flow through everything we do, or it's never going to be effective. And lastly, to essentially move forward and to start requiring data participation with the national framework that's established, that is receiving all this data and normalizing it, and then feeding the parts that need the data to make a difference. To just an earlier point, we have to get comfortable with, we can't have an 18-month period where that data, that lifeblood, is linking to metrics that are defining quality utilization. We've just got to get comfortable that we're not going to be able to act on it 18 and 24 months later when 99.9% of all the data is known. Typically, you've got about 94 to 96% of the claim run out within 6 months. And that's pretty much in my mind, the outside of when any provider or patient group can react to data and make changes in response to it. Past that, it's a dead issue and it's too late.
Thank you. Walter?
So I just wanted to circle back around to the whole discussion around kind of how the specialist fits in to the total cost of care. Excuse me. A couple of thoughts. I think one of the standout lines to me from our 2-day session this week was when Dr. Smith said, nesting is a disaster. And, it harkens back to a kind of old business school principle. If everyone's accountable for something, then no one's really accountable for something, right? And so I think as we think about total cost of care, it's crucial to assign accountability to a single organization, ideally single provider who can make a difference at the front line. But it can't be, in my mind at least, multiple providers with complicated carve-outs and nesting schemes. And so that's just one thought. Another thought I just wanted to share was I think there's bit of evidence in the literature that primary care is one of those few areas in healthcare where increasing the spend in that area actually decrease total cost, right? And so I think that's also important to keep in mind. And in my own practice and how I've, in my experience with others as well, who better to make the decision of how to use specialists and which specialists to use than the primary care doctor who's supposed to be coordinating the patient's care among multiple specialists, and that the weight of those referrals and the use of those specialists will, I think, even be more important if we give more accountability, both financially and quality-wise, to the primary care physician. So, I'm an internist, so I'm clearly biased in this arena, but I do think that sometimes we overcomplicate things, and we just need to figure out the kind of base entity or the base unit of healthcare in which to assign accountability, and then have that person just be truly accountable for the patient's care.
Thanks, Walter, for those comments. And Bruce, I do see your hand up. I'm just going to make a comment, and then I'm going to turn to Jen before you. Just two comments. I'm not sure when Dr. Smith was referring to nesting, it sounded like he was describing carve-outs more than nesting. It was like you're taking money out of the total cost of care, as opposed to the way I think about nesting. It's still within the total cost of care model, but then there's a piece of it that's sort of within specialty care. And I think the other piece I think deserves further conversation is around what is the right level of accountability. I know I asked Dana Safran yesterday on the quality side. When you think about patient outcomes, very difficult to assign that to a single provider. Similarly, around all of this, what is the right level for accountability as we think through this? So Jen, I'll turn to you.
I want to agree with Lee that I think one of the biggest opportunities that we have as a nation is to recognize access to meaningful, actionable data related to health is the great equalizer to help improve what are current disparities. And I agree with Walter that what I've heard over the last 2 days affirms that if we focus on the patient and patient-centered care, and we heard lots of great applications of transformation and care delivery models that are making a difference in terms of patient care outcomes, focusing on an accountable care organization might be too big of a swath, and that really getting down to the base units as you've described around an accountable entity, could be a provider, primary care or specialist, but that entity has to own everything, and we heard that over and over. So yes, maybe in heart failure, a cardiologist is the right person to own total care for a patient who is in a certain phase of disease progression. But then they have to own all their diabetic care, and when they have a stroke, their rehabilitation, and fill in the blank, fill in the blank. I think our payment models should be agnostic to ownership, but have a principle to prioritize that there needs to be an owner, because if not, there will be inefficiencies, and ultimately that leads to poor outcomes and higher cost. And so clearly by creating accountable entities, we heard strategies around buy, build, or partner. And that's my last comment, and that's those incentives to then partner with that accountable provider, group, or entity need to be compelling enough to want to create a relationship. And so I do think we need to go deeper and think about payment models that recognize that that relationship is both important and needs to be valued, and there's a cost associated with paying for those relationships.
Yeah, that's great. Thanks, Jen. Bruce, I'm going to turn to you.
Okay, thank you. I want to agree with both Walter and Jen. Beginning with Walter, he alluded to there's decades of research that shows that communities that have robust primary care are much better off in terms of patient outcomes and costs.
Bruce, sorry, Bruce, you're a little soft. If you can just get a little closer. Yeah, thanks. Sorry to interrupt.
Okay. Decades of research have shown that communities with robust primary care are much better off in terms of outcomes and cost per capita than other communities. And that's not even transposed primary care of the kinds that we're talking about now. Just as a footnote that's probably beyond our scope, the way that we select for physicians in this country discourages primary care, and Medicare adds to that discouragement by the way they subsidize medical education that's both hospital and specialty oriented. And if we think we need more primary care, and I agree that we do, it should be the transformed to sort of level 3 kind of primary care that Dr. Chen mentioned, that makes the primary care physician the quarterback, but extends the concept of primary care to be much more than just what the primary care physician does. And I'm in favor of that, but how we get there obviously is a problem. I do think that the organic way, I think as you called it, Paul, of dealing with the relationship between primary care and specialty care is probably the way to go.
Great. Thank you, Bruce. Appreciate the comments. Josh?
I appreciate the comments that were made. I want to kind of respond to a few of them. And I think this is actually really important for us as a committee and probably collective us as a country to grapple with. As a general internist who's also practiced primary care, I think, I don't want to speak for anybody else, but I think I believe in the same vision and like the values that we're working towards. I also try to filter through the fact that we've heard from some very good exemplar organizations that even across them, primary care has meant different things. And then I think about how even some presenters have talked about having a hard time finding primary care clinicians in key parts of certain states. And so as we think about scale, right, and things that might be done through this, I kind of oscillate between that, like what it could be in the best case, but then what might be a way to engage primary care more broadly speaking. And so I think, just to echo a few comments, I think how we get from here, given that variation, is to where we want to be is important. And are we solving for the exemplar, or are we solving for the norm? And how might models look different if we did that? And so, maybe it's a semantic issue around carve-outs versus nesting, but I do think I think the issues that we're talking about with sample size, attribution, all the things that have been brought up, do you take too much of the financial skin out of the game? What's patient-centric? Those are, I think, to me, it comes back to something that was in question 4, I think, which was, do we want flexibility or do we want more structure? And to me, TCOC models, as we understand them now, short of bigger changes like defining new costs, feel more flexible. So if we believe that changes need to happen, then I think we should grapple with things like nesting or carve-outs or dynamic ways of defining primary and subspecialty care. All are on the table from my view, but to then I think articulate early on all the problems with that, are we then suggesting in some ways something closer to what we have today? And that's an open question.
Great, thanks, Josh. Angela?
Yeah, thank you. So I just wanted to make the comments that I think this is one of the best meetings that I've attended since I've been on the committee. And so I just want to congratulate everybody that was involved and all of our great speakers today. And I think we agreed on a lot, and I think we agreed a lot around primary care and what primary care needs to be resourced with, how they need to function, and really creating a true transformation within primary care. I think we need to have a little more discussion in regards to the specifics of what some of those are. I do agree. I was a pulmonary critical care doc, and I functioned somewhat as a primary care physician for a lot of patients with various pulmonary issues, but prefer the idea that the specialists are part of the primary care team and not necessarily the primary care doctor. Because even in my practice, there were a lot of things that I didn't know about and wasn't covering. And so to try to function as a specialist and consider yourself as the primary care doctor and not part of the team, I think does give a disservice to the patient. And so we've got to figure out what that looks like and how to incentivize the specialist to be primarily responsible for what they're responsible for, but to be part of that team. I do agree that data is huge, and we've got to solve that problem because particularly early entrants into this just don't have the data to be able to make the right decisions. And then the last comment I want to make is there were some discussions about us not being ready for, not paying attention to the social issues, social determinants, accountable community type issues that affect our patients. And I don't think we can just put that on the back burner. I think that, the organizations I've seen that have really addressed those see such a benefit from it that we've got to figure that out. And I think that's got to be put back on the front burner. I don't think that the MLR can cover all the cost of all the social issues. And so we can't rely on the medical models to fix all that. So we've got to have some collaboration somehow with other agencies to help us solve those problems. But it's critical to get the outcomes we're going to need going forward. So thank you.
Great. Thanks, Angela. Great comments. Lauren?
So I agree with Angela. I think this has been one of the most stimulating meetings and interesting in my history of the last 2 years. So I think I reflect a lot on health-related social needs in these models, and these are the themes that I definitely heard. So across the innovations, utilizing data not only to understand the population, but to case find across systems and to build a comprehensive, deep patient story across EMRs was critical for integrating social needs, but also really deeply understanding what was actually happening with the patient. And then the theme of integrated teams, so bringing in social work, nursing, case management, community health workers, pharmacists, really building an integrated team and everyone operating to the top of their license, and then people spending their time only doing what mattered most from their discipline. So, for example, in hospice and palliative care, when the model shifted and it was no longer fee for service, it didn't need to be the physician that had the direction of care conversation because there's no longer payment attached to it. It wasn't a billable event. So then things shifted and people started to learn, well, what was 101 version that many people could do to a standard of care, and what required the highest level of education and experience to do. And that's how we sort out the delivery of our care, and that's how we carry it together and get more done in the visit that we have in the office and across systems as well. I heard a theme of really starting to think about care where people live. So definitely the primary care is the center, but outside of that office visit, how do we effectively and appropriately reach people, extend our services in the place where they spend the most time, and really deeply invest in relationship and trust building, which is where many of these models talked about actually seeing movement in outcomes. The challenge came up around there's been a lot of movement with health-related social needs screening, but we're navigating to nowhere. The lack of investment in those services, we can find out a lot about what's going on with people, but if there is no one to refer to in that community, there's really an imperative for us to look at that on a broader level and some ways of partnering and sharing to develop that. Also seeing new payment models under Medicaid that are starting to pay for that. So we heard some really exciting innovation from California where there's now payment for housing, there's payment for housing navigation, really enhanced care management for the most complex and vulnerable populations. And then what's happening from that is integration of healthcare and social services and community-based systems. So we heard of a housing and healthcare integrated system. We're seeing community-based collaboratives take on some of these social needs, including starting to blend and braid city funds, county funds, other sources of dollars that extend the table and the opportunities for really addressing social needs. And then finally, under the California approach, we also heard about payer collaboration that's emerging from that and how they're incentivizing that, again, to generate collective dollars to really deeply address health-related social needs. So a lot of rich material for future dialogue.
Thanks, Lauren, for those comments. Lee.
Yes, I was going to pick up a thread that we heard several different times, most eloquently today, that just as we turn our attention, and it becomes one of the CMMI focuses on, on diversity, equity, inclusion, and social determinants of health, and looking beyond the 20% that actual health care impacts, we need to take on this issue of rapidly diversifying social needs screening methods. And prevent, I love the phrase, prevent the cacophony from occurring that we've seen in the quality space. And that is very, very real. And it's going to happen unless we take proactive steps, and CMMI can lead the way to prevent that. And I would propose that just like I am not convinced there has to be 7 different standardized definitions of what a breast cancer screening quality metric looks like, there doesn't have to be 5 different ways and 5 different ways to ask the question to screen for a given social determinant. We just need a way. If we have 7 ways, it's going to distract everybody's time and attention to arguing which is the best and how to compare them, and one data set doesn't talk to another data set and can't be normalized. And that is simply distracting us from receiving the information and engaging with the actual need that our patients have. And so I think that is another opportunity for bold policy leadership that CMOI can step into.
Yeah, I think great comments, and we're so far down the quality, we're trying to come back to it, but now we're at as you're saying, we're just at the beginning of this whole measurement in SDOH. It's a real opportunity to sort of have CMMI sort of take a lead on how to move that forward in a rational way. Josh?
Yeah, I just want to maybe take Lee's point and kind of zoom out on it a little bit and say that I think one of the things I've heard from over the last few days from a few of our speakers is this idea that they are the financial, well, it's not about moving dollars, but the dollars are structured in such a way where they have the ability to buy an AC or to walk to the back and grab a nebulizer and give it to a patient. And I think there's a harmony between what they're able to do and then the big dot patient-centered outcomes are being held accountable to. Contrast that, I think, now under other payment structures where there's much more restriction, right? I just want to raise as something for us to consider is that holding clinicians, primary care and subspecialty care, different teams, different clusters of clinicians accountable for those ultimate patient outcomes when we don't have the ability to affect them. It may be 20%, we can quibble on the numbers, but 100% outcomes when we are affecting 20% and not resourced to do that, I think is not a bridge to a productive place. And so to me, it raises the urgency to address one of those things to get us into better alignment. Either we begin to look more like the flexibilities, or we think about the outcomes, or maybe something that's a combination of those.
Yeah, that's great. And I think I was thinking about, Angela, your comment about the MLR, and, so that we need partners on this. To the point about just SDOH in general and where to collect the data and how to implement. And it really need to think more broadly around, who those partners should be to really help with all of this. And I'm not sure who all those should be, but really, I think CMMI needs to think about that now, not only just the screening, but then moving who else in addition to the sort of the traditional healthcare system that can help with this work.
Totally agree with Josh's comments, and just want to resurface something else that we heard, and that many of these successful models have proactive outreach and actually high touch, ultimately high utilization. And so back to what's currently, considered to be within scope and out of scope, we've created models that incentivize higher patient panels and face-to-face interactions, often that are patient-driven. And what we heard today is flipping that model, or over the last 2 days, flipping that model on its head and actually having care teams direct the interactions in a way that benefits patients. So there's got to be ways to incent that kind of activity that ultimately improves health.
Yeah, I couldn't agree more. And I was thinking about that, thinking back to my own practice days as a specialist, when you see the patient, in the traditional model, you're not sure when they're going to get back to see the primary care doctor. Is the information going to get back to the primary care doctor? And then even if I have a recommendation that they see a different specialist, well, should I just make that referral myself because I'm not sure if, my recommendation is going to get back? So to your point, all these proactive touches will, at least in my view, raise the confidence within the sort of team that, in fact, that information, it always goes back to the information, is going to get back to primary care, who can then decide, yeah, that's an appropriate referral to someone else and reduce the fragmentation, et cetera. Yeah.
Well, Jennifer prompted something for me to remember, and that is that there really is very little way to pay for proactive care in the current fee-for-service model. And we heard from multiple speakers, fee-for-service is not going away. We're going to have to live with this some way in the future. We also heard that payments need to be timely, that value-based payments need to be timely. They can't wait for an 18-month reconciliation period. I live in this space all the time. We've talked about maybe not focusing on venture-backed entities. Well, the only reason I'm able to provide upfront money to providers is because of the financial backing we have. So it begs the question that we discussed yesterday on the chronic care management codes, the principal care management codes. Should we be recommending some adjustments to the current fee-for-service system that will allow us to bridge into the value-based care system more efficiently and effectively? Is there something we can do now that can do that? I realize that raises legislative issues that are beyond the purview of our committee, but if they're listening to what we're saying, maybe we need to make some adjustments to the fee-for-service or recommend changes to the fee-for-service system that will allow us to make this transition.
Yeah, and along those lines, I mean, CMMI has said, they have the ability to do the waivers just like they're doing for ACO REACH to waive, the co-pays from the patients. And so they could think about how more broadly to do some more of these waivers if you're in, some kind of total cost of care model. Josh?
I think connected to prior comments, but another theme that we heard yesterday and then I think kind of indirectly said today, and we've been talking about it, I think, in all of the things that I've been hearing, that I just want to surface is that, cost doesn't equal need. And relevant to total cost of care, I think if what we're talking about is identified need, either through just our clinical encounters, through screening, through data capture, through hoping more timely data and shared data, I think if we're thinking about that, one of the questions I posed to one of to the panel was around then how should that be brought into TCOC models? Should that be outside? Should it be collaborative, as we've seen in some states? I don't know. But if we're talking about need, mediated through higher touches and a broader aperture about how we're thinking about it, then I think pegging these models as the cost must come down, we may run into a challenge there. On the other side, I think one of the speakers today said, there are probably certain populations where there is cost to be taken out of the system. And so I think work to look at that is very useful. I think in that, my suspicion is that we'll find that it will be some collection of primary and subspecialty care, which is why I think this issue of how do we engage in this is so important, so we can actually identify those areas to then take a cost come down approach to TCOC models versus a needs-based approach. And just very quickly here, Larry's comment about, the financial ability to operate to me is a bit of a potentially a pragmatic one. We may wish for a different, current state, but where we are now, that's an ability to deliver the care we believe is right. In that same way, just going back to the point of primary care, I think we've heard visions of what primary care can be and should be and is in certain settings, but the pragmatism is that until we get there, I would love to see models and approaches that, again, bring primary and subspecialty care together so we can do that business of, is there really total cost to remove here, or is it more of a needs thing where we need investment? And those to me are very different.
Great. Thank you. Thanks for those comments. Under the topic of unintended consequences, I always like to talk about unintended consequences. So, but one of the topics listed under this, and Jay, you've brought this up a few times, is around pharmacy, which generally is not part of, total cost of care for some of the models, and whether really Part D should be part of total cost of care. We know the private payers often focus on, medication adherence, et cetera, in that world. The current models often, they include some of the Part B medication, but not the Part D. And so as we think about total cost of care, where does sort of the pharmaceutical spend sit and should it be? And to counter that, I'll just tell you from my experience, both when we've been in the oncology care model and when we were in the ESRD-ACO, over time, there were certain medicines that became available where all of a sudden costs went up astronomically, and then all of a sudden didn't look very good against our benchmark. So, there's not a perfect answer, but just in general, should pharmacy be something we should be thinking about, or, having some recommendations to CMMI as they're thinking through total cost of care? So any thoughts on that?
We should at least be including the drugs that are in the medical costs, because the shifting of costs between Part B and Part D that occurs with specialty pharma. I don't know how you wrestle with total cost of care unless you either have that totally out, which doesn't make sense since it's 40% of the cost of care, or you have to at least have those specialty drugs in that really blow up the cost on the Part D side and on the Part B side. I don't know how we talk about total cost of care without at least including that.
Any other thoughts on that? Yeah.
Yeah, I think I agree with that point broadly. I would just say even before we get there, in current models that look at A and B, I think many organizations that have been in these models have seen that Part B medication spending is significant. What's interesting to me is you double click and zoom in on that a little bit. The question is, to what extent, again, not to belabor the point, do primary and subspecialty care work together? And that exemplifies the point of the engagement, right? Whether, again, we're all in it together or it's in the sequence carved out. I don't want to get into the semantics, but even in Part B, over 5+ years of ACOs, I think we can see that issue come to play. I think the moment we then wrap D in, this issue is just only going to be magnified. So to me, it's like a precondition to really think through the specialist piece.
Great, thanks. So again, I know I brought up the pharmacy on the unintended consequences. Any other thoughts on any particular unintended consequences that come to mind as we think around total cost of care models? Yeah, Jen.
I know we talked about this briefly yesterday, but just to circle back to it, I don't know if it's an unintended consequence as much as don't forget to include, and that's back to what's high quality care. We all know value is quality to cost, and we've focused all of our conversation on cost, and we'll do so in the fall. But being explicit about what is the definition of quality for a given patient population is really important. And we heard today that, there's not a sustainable business model to do currently non-revenue generating activities to actualize what we think are high quality outcomes, because it just takes that long in terms of evolution of health, maintenance of health, or prevention of deterioration. And so we need to start thinking about process measures that accountable groups, i.e. providers, can own and be incented to do, that we know are good surrogates for achieving the outcomes that we want. And currently, what I've heard in these conversations is that that those are not in place, but these innovative care models are creating them within their own space and trying to create internal incentives that we could learn from. And I think there were quite a few that were described, including one that, again, I think this ratio of primary care touches to specialist touches is a surrogate marker for engagement. And to your point, Paul, of ensuring conversation, essentially, between the patient and the care team was an interesting idea. And so I think focusing more on, what's the definition of quality would be a really valuable conversation.
Thanks, Jennifer. Lee.
Yeah, just a philosophical underpinning that I've heard refrains of here that I think bear more noodle time and us thinking about and discussing at a future meeting, which is this question of, are we going to incrementalize our way to the glorious new future? And I propose the answer is no. And what I mean is when you think about, first of all, if you're going to incrementalize it, we'd have done it in the last 20 years of pilots and trials, right? We've already gotten there. But partly the science of change and performance improvement says at some point along an S curve, further input of resources doesn't increase improvement. You have to jump to the next higher S curve, right? We heard several good examples by Chinman and Prospero and others earlier yesterday. They did not incrementalize their way to their current state. They just changed their model and took a leap. I think that's a really important concept, and I'm not sure I've made up my own mind really where we are, but it's consistent with the path forward where we're not going to have a pilot model for every disease state. It looks like the future is fewer models, and they're more standardized and more broadly applied, perhaps in some areas non-optional. That feels like leaping to the next S-curve. And so I think as we keep wrestling with what this is about, I'm not sure, more codes to transfer value and a fundamental fee-for-service concept is going to get us where we need to go. We need to try to distill what has worked in whatever models we can think of and try to say, well, here's at least the skeleton of what the future model might look like. And it's up to people with, of course, the Secretary's encouragement to jump to that future in some fashion.
Yeah, I think that I appreciate those remarks. Really helps my thinking. And then also it begs the question, do people voluntarily leap, or do they need to sort of get them pushed, sort of mandatorily leaped?
Yes, they do.
Walter.
I wanted my last comment for this public meeting to be one of hope. As one of the newest members of the committee, I thought we were taking on a tremendous undertaking by trying to tackle the whole opportunity of population-based total cost of care. There's so much work that's been done upon this by many, many, many people and institutions. But one thing that leaves me really hopeful as we end our session is that we heard from a number of organizations over the past 2 days that are already doing this and doing this well and doing this with a financially viable model that also is hitting the quality metrics and having high net promoter scores and low patient disenrollment. And so I think there are models out there that we can continue to learn from, and we hope to continue this conversation in September.
Just to be clear, that doesn't need to be your last comment because, we can still, we have time to continue our conversation. But thank you for those comments. It's very helpful. Josh?
Gosh, I almost wish I made my comment before that comment of hope. No, I think I had a thought about unintended consequences, but I'll kind of loop in what I heard from Lee, which I agree with, which is that, we're talking about populations. Kind of the thing that lives on the back end behind populations is how you select those populations. And the thing that keeps me up at night, potentially, as someone who applies scholarship and evaluation to this and who helps lead things locally in my institution, is that issue of selection at the patient level, but also at the clinician level, at the group level. I think probably all of us have seen at least snapshots of that happen. And so I was trying to think through all the important things I've heard around this table and how many could be punctured by issues of selection. And I think probably all of them. So I just wanted to add that to the record, but say that I think the other theme, and I was actually counting it on our questions for our listening panel today, was that the number of times the word trade-offs came into, we brought up. And so I think at some point we need to trade and go. And monitor, yes, and be careful, yes. But I think if we keep propping up trade-offs and saying there are trade-offs, so there's an inertia to that. And so with respect to do they jump in on their own? Do we nudge them into jumping in? These are things we'll get into, I think, at the next session. But I would love to see us as a committee move from identifying those trade-offs to actually saying, in this trade-off, here's the put, here's the take. This is our recommendation, because we think this is bold. And at least that would be my hope.
Yeah, that's great. I think we spent a lot of time talking about data for performance metrics, and it's that data piece keeps coming back in the comments that many of you've made have really been foundational and really to move all of this. And in some of the models that we heard from, as some of the presenters also emphasize that, for their models work, they really need timely data. And for many places, this continues to be a challenge. Just either they don't have the financial wherewithal or don't have access to the data sources to really move this forward. And I think, again, this is something, and we talked about emphasizing the CMMI to think through how they can really help support this to really, if we're going to really continue to push, as you said, Lee, not so incrementally, but to really, it's hard to sort of push or make people do things if you don't have the tools for them to be successful. And I think that data piece is just a critical underpinning. So again, how you sequence things, that I think as we communicate to the Secretary and to CMMI, I think really needs to be emphasized. Jen.
Walter, I want to pick up on your theme of hope. I think over the last couple of days, and actually if I think over the last year or so, as we've been doing these theme-based discussions and having the opportunity to talk to leaders across the country who are just doing phenomenal things, really they're our early adopters. Despite our current system, there is a lot of really impressive innovation that's going on, and I am encouraged by the fact that these previous models and programs have sparked innovation that has helped us to understand what an ideal care model might look like or what does it need. And really we need to move now to uptake and then diffusion. And so that's that jump from curve A to curve B that, I think, Lee, that you were talking about. And, just to summarize some of those things, again, totally agree. Data infrastructure is a utility. It's got to be ubiquitous. We've heard that over and over and cannot be underscored how important that is, and that's real cost, real money, and real expertise. And so that seems like that would be an ideal investment from a federal or a state level, although we heard even at the state level, because of where patients seek care, that a single state strategy is probably unlikely to be successful. I think we've also heard that these programs cannot be voluntary because right now with how the incentives are aligned, even though there's been a conscious focus to not allow cherry picking, it still will happen. Unfortunately, right now, it seems to be the opportunities in chronic care management of some of our most frail and elderly patients, which is a good thing, but at other times the incentive might be for a different population. So the safety net these programs need to not be voluntary, and they have to include our safety net patients and program partnerships. But we cannot expect, as was described before by Josh, these programs to be implemented with all risk being put on the backs of providers. It is unfair and it's unrealistic, and they will balk, and we need them to participate in a meaningful way, because when they are leading decisions in care teams, we get great outcomes, and that's actually what we want to try to achieve. And so I think what we heard with our last panel of really thinking about how to incent closing the gap in areas that we know are the biggest barriers, access and coordination, are potentially ways for us to be thinking about how to go from these wonderful pilots of innovation that shows that it can be done to creating this uptake and diffusion. I think that's where CMMI has a real opportunity. So I agree with your optimism.
Thank you. Bruce.
You hear me okay?
Yes.
For just a couple of minutes, I'd like to defend the concept of moving money around, which somehow seemed to be cast in a negative during much of the discussion. Historically, in Medicare, moving the money around often meant trying to move money within the fee-for-service system, which maybe had some limited success in supporting primary care, but I would say very limited. But if we're now talking about moving money, and someone did say, maybe it was Lee, there's an incentive to move to a different mode of practice, a transform mode where there's a team approach to care. And that needs to be attractive. And there certainly can be attractions other than monetary, but certainly there has to be monetary. At the same time, there can be, and many people think there are, and there's lots of evidence that staying within the fee-for-service system has mounting unattractive features, many of which are navigating adjudication, things like that, that can be relieved from the physician who practices in a different setting. And so the notion that moving money around is somehow distasteful, I think, is incorrect. I think we need to think about how to accomplish an objective through moving money around and also through other mechanisms that go along with it.
Thanks, Bruce. We appreciate the perspective of the economist. It's where you do have to think about money. It's important. Before we close, any final comments from any of our committee members? Great discussion, great feedback. Audrey, I'm going to turn to you to see if you either have other questions or clarifying points you want from the committee, or let us know.
Thank you. So first, I would like to ask if the other ASPE staff have any points that you guys might want to make. Lisa, Steve? Okay. So I just had one follow-up question regarding one of the issues that I think Chenny had raised during the PCDT presentation yesterday as one of the things that maybe you were trying to think about. And I think you've touched on it a little bit, but there's still, at least from my hearing, I still had a question. When we began the theme-based discussion yesterday, Debbie Zimmerman had kind of talked about the need for, as part of total population based total cost of care models, looking at managing to achieve lower cost for high-risk patients, as well as making a significant increase in investment and services for lower risk patients, so that both of those needed to happen at the same time. Today, we heard one of our panelists say that if total cost of care is the top priority rather than quality, then there's a need to focus on the populations where we believe that we can achieve total cost of care reduction. So I'm wondering if you guys have come to a point of thinking about, should the focus within these models be more so on the higher cost patients, chronically ill, higher cost patients, versus on kind of what was referred to as that broader tail, that maybe they have lower cost right now, and the prevention of that, and then how do you, I guess in September, how do you manage the cost associated with whichever strategy?
Angela?
Yeah, I think we have to spend some time discussing that tail, particularly that group, just the rising risk group, and identifying, and there is some ability to identify who's going to be increased, who's going to need increased resources going forward. As a pulmonologist, COPD gets worse, and you can't change that pathophysiology. They're going to get worse, and they're going to start utilizing and needing hospitalization, et cetera. And the earlier you intervene in those things, the better. So you're not going to prevent everything, but I think we have to pay attention to those rising risk patients and fix what we can and mediate what we can't fix. So.
Yeah, I would agree with that. I mean, I think, and I'll get to everyone else said, and I think maybe Larry, you said this, a patient who cost a lot last year isn't necessarily the one who's going to cost next year. And so, you really need to think about the whole population, particularly the rising risk, as you alluded to. Larry.
I jotted down that I was impressed with Dr. Zimmerman's slide 4. I mean, I think that really tells the story. And when you're looking at it from a population point of view, you got to invest. You got to invest in the early care, and those people may have low risk now. And if her curve is accurate, then you're avoiding the higher cost, higher risk deterioration later. I know in our population of inflammatory bowel disease, someone could have they can vary from year to year to year. So unlike illnesses like COPD that once they reach clinical significance, they're going to continue to deteriorate, there are many illnesses that have periodicity to them and we heard from our actuary that, like the stock market says, past performance doesn't predict future performance. So I think I would lean more towards Dr. Zimmerman's approach.
Josh?
Audrey, thanks for bringing this up. To me, there's at least 2 distinct issues here. The first is in managing populations, do you focus on the tail, or do you focus on the bell, or like the middle of the distribution? I think it's a both and. My sense is early on, maybe the people in the tail that can help, but you're going to want to move people across a population, at least ostensibly that's the goal. I think in recognizing that, though, because just like in the clinical context, when you give a medication, often you get the biggest effect for the people who have the least well-controlled disease. If you intervene early, how would you measure that improvement in someone before they've gotten, out of that range? I think that speaks to the importance of quality measures in that. So I like the idea of taking the broader approach. It may be staged. I think a focus on quality. The second issue to me is what to do with the tail. And for the reasons that Paul and Larry have mentioned, I think it's not one group that never changes. But I go back to my comment about cost not being need. If we think that they are in the tail of that curve because there's something that we can do less of because they don't need it, it's overuse, it's potentially unwarranted, then I think those models should push us to that. I think if it's a need and they actually need more services, different services, right, to move them out of that tail, which I think everybody probably wants, then I think the traditional TCOC approach of doing less is probably not the right thing. And then we're talking about investment within these models, adjacent to these models in a collaborative way. Again, I don't know, but that's how I think about that.
Great. Thanks, Josh. Audrey, any other clarification?
No, thank you.
Okay, great. So I want to thank everyone for participating today, our expert presenters and panelists, my PTAC colleagues, and those listening in. We explored many different facets of population-based total cost of care models. Special thanks to my colleagues on PTAC. A lot of information packed into these 2 days, and I appreciate your active participation and thoughtful comments. We'll continue to gather information on our theme through a request for input, which is posted on the ASPE PTAC website. You can offer your input on our questions by July 20th. Now that we have explored relevant care delivery innovations, the next step is to dive into the financial incentives to encourage these, which we will do at our September public meeting. I hope to see you all then. The meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.